Good evening. Welcome to tonight's COMS educational webinar. Just a reminder for anyone who has not turned off their camera and microphone to please do so. Hopefully for most of you, spring has brought less snow, more sunshine, and a renewed sense of vigor after another winter. I hope that your summer plans include attending our COMS annual conference in Saskatoon, June 17th to 19th. For those of you who never been to Saskatoon, Saskatchewan, this is a great opportunity to attend, and I know you'll be surprised, not just by the city, but by the terrific conference we have planned for you. One of our sponsors at the conference, Straticyte, wanted to share exciting information on what they are doing prior to the conference and what has brought us to tonight's webinar. We first met Dr. Barry Rennick in Vancouver at CAOMS, and when he shared with us the work he was doing. And so tonight's webinar is intended to showcase this new technology. Our two speakers tonight are Dr. Barry Rennick and Dr. Simon Young. Dr. Rennick is an OMFS with an interest in oral disease, cysts, and tumors. He has been in private practice in Newmarket and a staff surgeon at South Lake Hospital for over 25 years. He is the only dentist in Canada with dual specialty training in both oral surgery and oral pathology. His training includes experience at Toronto General and Toronto Western Hospitals, the Wellesley Hospital, Sick Kids, Sunnybrook Hospital, Odette Cancer Clinic, Princess Margaret Hospital, and Sunnybrook Interdisciplinary Mouth Clinic. Dr. Simon Young is an assistant professor and director of research in the Department of Oral and Maxillofacial Surgery at the University of Texas Health Center at Houston School of Dentistry. He received his dental degree at the University of Toronto, his doctoral degree in bioengineering at Rice University, and his medical degree at the University of Texas School at Houston. He completed his residency at UT Health. His research efforts include the synthesis and characterization of implantable biomaterials designed to elicit in situ cell recruitment and programming. His work includes use of materials able to simultaneously deliver multiple bioactive factors with distinct release profiles. These constructs have been used in a diverse set of applications, such as the promotion of craniofacial bone regeneration and cancer immunotherapy. He has broad experience in the fields of polymer synthesis and cancer characterization, growth factor delivery, in vivo models, characterization of bone and neovascularization, cancer immunotherapy, and implantable therapeutic cancer vaccines. In addition, he is a board-certified oral and maxillofacial surgeon with significant experience in the treatment of reconstruction of craniomaxillofacial trauma and pathology. The focus of his current research is to develop novel material-based immunotherapies for the treatment of head and neck cancer and explore mechanisms of how this approach may synergize with other modalities of treatment, such as chemo and radiation therapy. The paradigm of in situ cell programming using biomaterials is also utilized in separate research projects in collaboration with MIT and Rice University, exploring the use of layer-by-layer technology to deliver bioactive factors for the enhancement of craniofacial bone regeneration and multi-domain peptides for nerve regeneration. He currently holds the Young OMS Research Professorship. He is a fellow of the AAOMS, AACMFS, and ACS. In 2020, he received the AAOMS Faculty Educator Development Award, a prize given to only 4 emerging leaders in the specialty each year for his groundbreaking academic contributions, most notably in biomaterials development for tissue engineering and cancer immunotherapy applications. Tonight's webinar will be moderated by our very own Dr. Tony Shahade and will consist of a series of questions that Tony will ask our two speakers. For all of you listening, please feel free to type your questions in the chat, and time permitting, Tony will address those as well. Just a reminder that webinar will be recorded, made available on the COMS YouTube site, where you can watch all previous webinars. Please welcome Doctors Rennick and Young, and I will turn the microphone over to Dr. Shahade to begin. Thank you. Tony?
Thanks, Rob, for that introduction, and welcome to all of our participants who are out there across Canada, hopefully, that are listening in. Thank you, Dr. Young and Dr. Rennick, again for joining us. And so we're going to jump right in with some questions that we want to ask you to highlight the topic of tonight's webinar. So Dr. Young, I'll start with you. And I'll ask you, based on your experience, what do you see are the challenges with the current standard of care in oral cancer?
Thanks very much for starting off the talk. So let's just do a little bit of a rewind first. And if you think about, 40, 50 years, if you look in the 1970s, and you think of the large categories of cancers that we're familiar with, like breast cancer or prostate cancer and oral cancer at the time in the 70s, you were looking at 5-year survival rates, around the 50 or 60% range. Now, fast forward to now, there have been vast improvements in those other diseases. So, breast cancer, you're looking at 5-year survival rates, around 90%, prostate cancer, 95%. And where are we with oral cancer? We're still, unfortunately, around the 50 to 60% range, depending on, how advanced your healthcare system is. And so that's obviously a problem. We haven't made the strides that we would want to make. And if you look at the statistics in terms of the math, in terms of US numbers, one US person will die every 45 minutes from oral cancer. And another sort of alarming statistic is that for young folks, so interestingly, sadly, young adults who are non-smokers and non-drinkers, that's also sort of an increasing category of incidence for oral cancer. So there's a lot of sort of alarming signs in terms of which way oral cancer is heading, and no real great advances over numerous decades in terms of our survival rates, unfortunately.
So, relatively speaking, why do you think we haven't made any headway in this domain?
Yeah, so if you take things like breast cancer and prostate cancer as an example of where they've made improvements. So obviously part of it is advocacy, right? They have very good, and prevention is also, very important, right? So they have very good advocacy for their groups. They promote a lot of preventive measures. And you may have even heard here in the US recently, it was in the news that they've actually recommended now that mammograms take place at the age 40 and not 50. So I think the public is very aware of that. And then of course, on the clinical side, it's possible that clinicians who treat breast cancer and prostate cancer, they're catching those diseases earlier on in their development. So, of course, as we all know, the earlier that you catch a cancer before it's spread, before it's got enlarged, before it's invaded, or even better, if you get it in the pre-cancer stage, that's a much better prognosis. And we haven't really been doing that for oral cancer for various reasons. And I'm sure everyone on this webinar is upset if someone walks in with a large T3 or T4 lesion in the oral cavity, and you say to yourself, why were you, living with this red and white fungating lesion now in the things like 4 centimeters? Like, didn't something alarm you about that? So, obviously there's an educational component, but, think about things like breast cancer, and the education the public has, whether it's the public or celebrities. I mean, most people now have heard of the BRCA1 and 2 genes and how those things are linked, to high risk breast cancer, for example. And they've also made a lot of strides in terms of their omics testing, right? So whether they are testing these sort of pre-malignant breast lesions, using proteomics, looking at, proteins, or genomics and looking at genetic information, they are making strides in terms of trying to predict whether these pre-malignant lesions will become cancers. And there's even sort of interesting technologies now where they can look non-invasively. So they're very interested in saying, for example, can you now do blood tests or saliva tests to detect tumor DNA that's flowing, in your bloodstream. So there's a lot of sort of strides that are that are being made in other cancers. And, they say that, a lot of these breast cancers, they can be surgically prevented by removing some of these precancerous lesions, when they are so really early, maybe only when they're sort of micro-invasive. And the problem is, in oral cancer, we haven't done that. We haven't adopted that same philosophy that other sort of successful oncology fields have done. right? And so, if you look at the statistics, again, a lot of our oral cancer patients, they're presenting with advanced disease, which is unfortunate. And yes, if you look at over the past 2 decades, there have been strides in terms of the way we're able to resect these cancers, the way we're able to reconstruct these craniofacial defects, the imaging modalities we have, the radiation oncology, and the way we sort of deliver radiation and chemotherapy. But still, that number hasn't drastically changed. And like I said, 1970s, survival rates in the 50 to 60% range, we're still looking at that now. And we still are dealing with, high recurrence rates, with only very, very small improvements in our 5-year survival rates for oral cancer. And take, for example, even some of the newest modalities of treatment that are FDA approved here, in the US and I'm sure in Canada as well, like immunotherapy. Immunotherapies is still, for their indicated, patients, they're still only looking around a 20 to mid 20% success rate in terms of their survivals at 5 years. So I think the take-home message is that in oral cancer, we're really failing as a profession to intervene at the earliest stages of cancer development because, we haven't been identifying those sort of high-risk patients that potentially don't look high risk to the eye, but they actually really are high risk. And we're not properly managing those patients. So when they come to us, it's very late in the disease.
It's interesting. So I guess, well, first is the challenge of how you identify a high-risk patient, which we'll presumably get back to shortly. But I guess I would ask you, how would you currently manage patients at risk of developing oral cancer? Start with that.
Right. And that's, those conversations that we have are similar to talking to people about, let's say, cervical cancer. In our developed countries, we are fortunate to live in North America, where we have very good screening procedures, and all females are aware of things like, screening through pap smears to prevent them, from getting advanced cervical cancer. And so when we talk to our patients about, oral cancers, the reason we all do these head and neck exams and we're all screening because we're looking for small lesions that are potentially, precursor pre-malignancies. Because as we all know, cancer is essentially a set of mutations that allow these cells to proliferate in an uncontrolled manner and potentially metastasize. And so virtually all these oral cancers at some point started off as these precursor sort of pre-malignant lesions. And of course, this may be, broadly applicable to other cancers. And so in the mouth, these lesions have been defined by the World Health Organization as these so-called OPMDs, which are oral potentially malignant disorders. So there's 11 of them, and they include things like leukoplakias, erythroplakias, proliferative Bruchus leukoplakias, lichen planus. There's a whole bunch of them. There's about 11 of them. But if you look at the conservative estimates for those diseases, for those entities, about 2% of our population harbors these lesions at any one time. And the most common sort of way that these OPMDs are seen are, the so-called white patches in the mouth, these so-called leukoplakias. And so the real question is, if these things are pre-cancer, what's the transformation rate? So if you look at the literature, about 5 to 15% of these, these pre-malignancies, these OPMDs, they will transform to the most common kind of head and neck cancer, of oral cancer, which is squamous cell carcinoma. And so, we would say that, identifying and diagnosing these OPMDs, that's not the hard part, right? I mean, if you finally have someone, if you have someone come into your clinic and they have a white lesion, the hard part is not diagnosing whether they have an OPMD. The challenge, as it's for the longest time, has been which of those OPMDs will actually become cancer. Has there ever been a predictable way to say whether things will progress from just being a so-called precancerous lesion to actually becoming cancer later on? That's always been the challenge. And a huge part of that challenge also is that, if you can't predict well whether something will become a cancer or not, it's hard to relay that to the patient and the seriousness of that. And full disclosure, in some of the work that our center here in Houston has done with Straticyte, it's really hard to have patients come back for 5 years. So, if someone comes in with a so-called, mild dysplasia, they might come in for, a few of their appointments, during the first year, but they might not show up in the second, third, or fourth, or fifth year when they may recur. So that's definitely a problem, even on the education front. And and so bringing up the whole issue of dysplasia, that's the current standard of care, if we want to call it that. That's the best we have. It's dysplasia grading, right? And that's like old school H&E. Those dyes have been around for decades. And to this day, decades later, that's still the standard, right? We identify something in our patients that looks suspicious. We do a biopsy and we send it off to the pathologist, and they come back. And if it's some sort of premalignancy or dysplasia or histology, the pathologist will take a look at it and they'll say, well, this is either a mild or a moderate or a severe dysplasia, if it's a dysplasia, based on, the thirds, whether it's a third of the thickness, 2/3, or full thickness. And that is, that's been shown, number one, to be fairly subjective. It's not very reproducible. And that system, which we've been using for decades, doesn't have a really great predictive value to them. And so, absolutely, I don't think anyone in my faculty or any, practicing oromaxillofacial surgeon would not take severe dysplasia seriously, because we all know those are very high risk. But, what the problem is that there's still a fair bit of mild, so-called mild or moderate dysplasias, or even, people who don't have dysplasia per se, and those things can still transform. And so, Dr. Rennick and I were discussing recently in a paper. If you look in the journal of the NCI, which is the National Cancer Institute, they had a paper in 2020 by Chaturvedi et al. And interestingly, so that was a retrospective study. They looked at around 1,900 patients from the Kaiser system in California. And, when they looked at their samples, about a third of the oral cancers in that study, they developed from lesions that did not get a dysplasia read from the pathologist. So clearly, the problem is that we've been saddled for decades with this old system where we have not been able to really correctly or accurately predict whether these sort of mild or moderate or even no dysplasia, cases become cancer. So the real question is, what value does this conventional dysplasia grading have, even though we've been stuck with it for decades now? Oh, sorry, I think you're muted.
I am. I apologize. Quick question for you. You mentioned that 1/3 of cancers in that study were not diagnosed as dysplasias. Does that mean that the lesions weren't visible, or were there changes that provoked a biopsy, obviously, and the lesions were detectable?
Yeah, so my interpretation, and I guess that's the difficulty of the retrospective data, these things, who knows exactly what it was, but clearly these were lesions that were seen as being suspicious from their clinicians sending it in the biopsy. And then so whatever looked clinically suspicious was not read by the pathologist as having defined mild, moderate, or severe dysplasia. So it may have been like cellular atypia or something they were uncomfortable calling dysplasia. So
just to organize this for the listeners, can you please explain what the shortcomings are of dysplasia grading as it stands?
Sure. Yeah. And so again, I would say the important thing to reiterate is, based again on H&E sort of staining, and if your pathologist, if your friendly neighborhood pathologist, sees this slide and they decide that based on the architecture and the cytologic findings that they are seeing dysplasia, they will get back to the clinician and tell the clinician whether they feel it is mild dysplasia, i.e. only occupying a third of the thickness of that tissue, moderate, which is 2/3, or severe, full thickness, or carcinoma in situ. Now, the problem with that, again, is that it's a histopathologic finding. So there's two problems with that. So one is, as we've mentioned, between pathologists, or even within the same pathologist, let's say you show them a slide and then they go see a bunch of other slides and you show them the same slide months later, there's poor inter-pathologist, consistency and intra-pathologist consistency. So that's a problem. But also, it just has poor predictive value. So what we've learned over time is that there's no way to exactly tell when someone gives you back a read of mild or moderate dysplasia to know exactly if that patient's going to get cancer or not. It's never really been quantified. And so, in an effort to try to make our predictive algorithms a little better, the folks in the UK, so there's something called the SPIGHT, SPEIGHT algorithm. And there's also a Liverpool algorithm, and so those two separate groups in the UK have tried to improve sort of the prognostication of these dysplasia gradings by combining it with clinical sort of characteristics. So they'll say, well, male versus female, smoker versus not smoker, age, all these kind of things. And they'll try to like lump that in and combine it with, their histopathologic findings to try to improve on the sort of the prognosticating ability of the dysplasia grading. But, at its core, the problem is you're still relying, those algorithms still rely greatly on these dysplasia gradings. And so, talking to Barry about this, and I'm not an oral pathologist. I mean, Barry's, one of the very, very rare oral pathologists and oral surgeons in Canada, of course. And he's told me that, oral pathologists, they even themselves may be frustrated with dysplasia grading because, the difficulty is there's two ways to go about it. The pathologist can say, well, this is what I see. It's mild, moderate, or severe. Do with it as you wish. Or maybe they don't want to give you a treatment recommendation or observation recommendation. They just say, atypical epithelial proliferation and just observe it. Or, and that's the most they might want to do. And so, I think the problem is in traditional formats, when we get back these pathology reports, we're not getting the guidance that we would like. And so of course, at the end of the day, every clinician who has the patient, in their chair, they're responsible, for their treatment once they get the diagnosis back. But, wouldn't it be nice if we had a much better way to take a biopsy from a patient who has a suspicious lesion, send it off to some sort of more quantifiable test, and then get back something with a little more certainty versus, oh, yeah, there's dysplasia. Just watch it. Don't know what to say. What else? And I think that's why we're all here today, because, we're interested in hearing from, Dr. Rennick and other colleagues about what strides have been made recently in terms of trying to get more, bring sort of molecular findings into the clinic to try to prognosticate these dysplasias a little better.
So I'm going to turn things over to Dr. Rennick. So I think it would be very apropos to talk about the new developments and innovations such as the Straticyte test. Can you tell the audience a little bit about this test?
Sure, absolutely. I just want to get back to a couple of things that Simon was talking about there. That Chattaverity study, that was actually a study of patients with leukoplakia. And so you were asking about the clinical significance in that study, and that's what that was. And it was actually about 39% patients that had leukoplakia that went on to develop cancer actually had no dysplasia whatsoever in their biopsies. We're hanging on to dysplasia grading. I guess like the early colonists or the early explorers hung on to the world being flat, and it's been very, very difficult to try to make inroads into trying to come up with a better system of prognostication for these patients with potentially precancerous lesions, and the struggles that pathologists have had for pathologists have been struggling this for years with this problem. And there was a fellow actually by the name of Bozeman, and you could check this paper out. It's the paper was entitled "Dysplasia Grading: Pathology in Disgrace." And his comment, he was actually an anatomic pathologist, and he was studying primarily cervical dysplasia. And he proposed that dysplasia grading was so absurd that they should actually have a classification within it called "I don't know." I really don't know. I think he really meant I really don't care. We know that these patients all have the potential to go on to malignancies, but we don't really identify them accurately using dysplasia grading. And just further to Simon had commented about, sometimes, as of late, I've been getting reports back that said epithelial atypia, continued observation advised. Pathologists themselves are getting, have been frustrated with dysplasia grading for years, but it's almost as though dysplasia grading is something that they're saddled with, that they have to come out with a dysplasia grading and report back to the patient. There's been a couple other interesting developments. We'll talk about Straticyte in a minute, but I was at a meeting recently, and there was a couple other interesting comments people had. And one was that they felt that dysplasia grading was so poorly reproducible that no report of dysplasia grading should go out unless it's co-signed by 2 or 3 pathologists. And they went further to say that if you're going to actually be reporting on oral pathology cases, and you're going to be incorporating or using dysplasia grading, you should actually probably be reassessed by an external assessor once a year to see whether you're still up to scratch on your skills. But we know that dysplasia grading is poorly reproducible, and it has very poor prognostic values, but we still continue to hang on to it. So there was a paper in OOO, I think it was, or it could have been JOMS. It would go back about 15 years ago, and it was by Paul Edwards, who also happens to be from Toronto and currently is the head of pathology, oral pathology in Indiana. And he wrote that until we find a cancer-associated biomarker that we can quantify and correlate to outcomes with these precancerous OPMD patients, we're going to continue to struggle with these patients, particularly those ones that are of the non-severe dysplastic group. So people in Toronto started looking at, trying to solve this problem. And the Straticyte, test actually has a little bit of history. It goes back, to probably about 2010. The Straticyte test is the world's only truly objective predictive test for OPMD patients, and it's based on the bioprotein or biomarker, cancer biomarker S100A7. It also combines with it a cytomorphometric analysis of the epithelium as well. So there's 2 components. One is the biomarker, and the other is using actually computer-driven AI technology to remove some of the reproducibility issues associated with dysplasia grading. So it does cytomorphometrics. It looks at cellular size, cellular density, nuclear cytoplasmic ratios, presence or absence of mitotic figures, and then takes that and combines it with S100A7 protein assessment. So what about S100A7 protein? It was actually first discovered in 1991, and it's also known as psoriasin, and it was discovered in abnormal keratinocytes of psoriasis patients. From an evolutionary standpoint, it seems to have some antibacterial properties for against E. coli, and so prevents E. coli from invading into open psoriatic wounds. But it also is associated with many cancers, and it is involved with the RAGE pathway that facilitates epithelial proliferation and also epithelial invasion. And S100A7 is not just common to oral cancers, but it's found in many cancers, breast cancers and prostate cancers and lung cancers and GI cancers. And, it's in those patients that have high levels of S100A7, they actually have a poor prognosis with their treatment. And if we go back to 2010, the story of S100A7 and the mouth begins actually in India. There was a limited limited amount of funding available for managing oral cancer patients. And in India, they see about 150,000 new oral cancer cases a year. And most of these patients have a poor outcome because of treatment. But where treatment's available, they were trying to find out how they could better spend their money. Was there a marker that they could identify that could help demonstrate the patients who are going to have a better outcome? And so they found that patients with high S100A7 didn't do very well with treatment, regardless of what treatment was offered to them. And as a spin-off of that study, they found that patients that had dysplasia and had high S100A7 in their tissue were likely to develop carcinomas down the road. Now, they weren't particularly interested in the dysplasia study, and it kind of got shelved. And it was picked up later in Toronto by a group of scientists at Mount Sinai Hospital. So they were able to, they actually looked at 811 possible biomarkers that could be used as predictors of dysplastic tissue transforming into cancer. They came down to 5 potential candidates, and then S100A7 again came to the surface. It was the one biomarker that really had the best predictive value. So they took this. It started out with 811 potential biomarkers, and that's what they ended up with. Now, these early studies were actually done using really complex mass spectrometry and chromatography studies, but they were also able to show that you could do this fairly simply with a microscopic slide of the tissue. So if you took a dysplastic patient, their microscopic slide, and you were to stain it for S100A7, they got the similar results, that those patients that could be that had tissue that was stained immunohistochemically for S100A7, those patients also had poor prognosis. And it's very simple to stain a slide looking for S100A7. You take some mouse anti-human anti-S100A7 antibody, and then that antibody is tagged with a chemical marker, and then you can look at this under the microscope, and tissue that is densely brown staining is tissue that has high S100A7 and is tissue that's likely to transform into cancer regardless of what the dysplasia grading might have been. So that's how the Straticyte test works. It gets away from the 1/3, 2/3, 3/3 architectural studies that or basis that the World Health Organization dysplasia grading system uses, and it's based more on cytology and also the quantification of this S100A7 biomarker. And the Straticyte test was first used in 2014. It was part of a Canada-wide early research study. It wasn't available commercially yet, and there was also another center in Alabama that was involved with this early observational study as well. And then the product became commercially available just a couple of years ago. So we finally had a test that was based on a quantifiable biomarker, and also that looked at cytomorphometrics. And this is all done through AI technology. So we use the original biopsy specimen of your patient. We cut a couple of extra slides of it. We stain it with S100A for S100A7. We then take the slide and stick it under a digitizer, and we get a digital slide image. The digital slide image then goes into a slide reader that's hooked up to a program that's proprietary to Proteocyte. And then that slide reader actually quantifies the S100A7 and counts all the cells. And it spits out a report, a Straticyte score, which is based on the cytomorphometric study and the S100A7, and it's compared to a group of patients that we've been following for now over 20 years that have known outcomes. And in that group of patients with known outcomes, patients that had dysplasia and had highest 100A7 were the ones that would eventually progress onto cancer. So that's basically how the Straticyte test works. It's S100A7 biomarker, cytomorphometric analysis, AI driven, and there's a proprietary algorithm based on the study of 150 patients that have been followed for 20 years or so. But this algorithm's become stronger and stronger as we've now added about 1,000 cases.
Okay. So it sounds extremely thorough. It adds certainly another dimension to measurable parameters, as you've mentioned. Is this something that's easy to implement in the average private practice? And I guess part two of that question is it something that's covered by a public regime, or is there a out-of-pocket cost to the patient for this?
Yeah, I can answer that. So it's actually always fun to hear Barry talk about like the history of this test and what's done on the background, because on the clinical side, you don't actually see all that sort of complexity. It's actually like way easier, right? And so Straticyte has been available here in the US for about a year now, so since early 2023. And so, through their early adopter program, some of us here at UT have done it and tried it out on our patients. And so, when we initially engaged Proteocyte and they said, their slogan is order the test and we do the rest, we had to kind of see for ourselves how that would actually work. And it is true, you can incorporate it quite easily into your practice. So, as Dr. Rennick was saying, that imaging that's done on the slide, the staining, you don't see that in your practice. The clinician's not seeing that, right? And so essentially where we engage the platform is at the point where you've already done the biopsy, you already have, the report back from, your pathologist, and you have your patient in the chair, and you're breaking the news to them that they have, an OPMD, they have a dysplasia. And so, in your mind, before they even sit down in the chair, obviously you knew what that diagnosis was. So you're already thinking whether this is a Straticyte candidate or not. And then so you sit down with them and you inform them, obviously, the seriousness of this potential precancerous diagnosis. And, we give them a bit of a spiel in terms of, yes, for many years, H&E has been the standard and dysplasia grading has been used, but there are sort of, newer, more advanced techniques now that are objective. And there's a couple even sites that they are referred to because we have the brochures for Proteocyte, so we can hand them the brochure and say, listen, you can take a look at this brochure and read through it if you want, and look through some of their literature. There's like a clinician sort of part to the website, and there's also a patient side to it. And we explain to them, exactly what Barry and I have been saying here on the webinar, where, yes, we've been using dysplasia grading for a long time, but there are pitfalls, and, there actually is something else that can be used now. I mean, 10 years ago, that's all you got. You only had dysplasia grading, but now there's this new test. It's called Straticyte, and they can look that up. And in terms of the cost to the patient, at least for us down here, we've been part of something called the early adoption program. And so, our patients were getting charged $500 US, which I understand from the company was about 650 Canadian, north of us. But essentially what we tell the patients is that for this test, it'll give you sort of peace of mind for the next, 5 years or so, because that's what the data, that's the data horizon. So if you look at our data, the studies are done over 5 years. So we can't prognosticate 10 years out, but at least in terms of the test and the limitations of the test within 5 years, we can say that this is going to basically help us monitor them and give them more peace of mind, because what this technology does is risk stratify them. That's the whole point, right? So if you do the math and figure it's $500 for 5 years, it's $8 a month. So
what is involved? So you mentioned the monitoring.
Mm-hmm.
Does that imply repeated biopsies every year?
Right. And so what this means is, so monitoring is essentially so let's just walk through a scenario. So a patient comes in and I biopsy them already, and I know from the report it says mild dysplasia. And so they'll sit down, I'll say, listen, you have a diagnosis of mild dysplasia. This is what that means, based on the traditional staining techniques that we've always been using. I can't tell you for certain, whether this will become cancer or not, but you do have a finite risk. I don't know what that risk is. It may transform, it may not, but if you run this test, we will be able to see with this test and get some extra information. And so they might ask, well, what extra information is going to be useful here? And so the idea is that you can say, well, if you allow it for and you want to pay for this, Straticyte, they do the work. So we fill out this form, and this form has the patient's information on it, and they also have the lab's information, the lab that did the original pathology. And what Straticyte does is they do the billing with the patient. They contact that lab. They get that lab to send Proteocyte a couple of the slides. So Proteocyte can do the staining and the analysis, and then they send back a report in a couple of weeks. And what we tell the patient is, say, listen, when this report comes back, it's going to help us determine, what sort of category you're in. And so you're either going to be in the so-called low risk category or maybe a moderate to high risk category. And the reason that matters is because imagine you walk out the door right now and you have this diagnosis of mild dysplasia. I don't know exactly what to do with that. I mean, you may never get cancer, but you have some sort of small finite risk, but I can't tell you with any certainty any better than that. However, and so if you say that to the patient, they say, oh, great, I'm low risk. I'll see you later. And you say, well, come back and see me every few months, or come back in a year, come back yearly. Yeah, thanks, doc. And, some may not. They're just going to go live their lives. Now, what if you do that test and there's two outcomes, right? Either the Straticyte test says you're low risk, and so you can put them in a certain observation schedule, and Dr. Rennick has his own schedule, and he can talk about that. And you may monitor them a little less frequently, or the test might come back and say you're high risk, right? Meaning histologically they may have come back as a mild dysplasia, but remember, that's old school, right? You're looking at H&E, and your eye and the pathologist's eye, looking under a microscope at pink and purple things, can't look at a molecular signature, right? So the whole idea is that you tell the patient, well, listen, this stain for S100A7 combined with the sort of the AI-powered sort of morphological determination of the risk here is going to give us a little more insight into sort of, risk you have, because it's seeing things that the human eye can't, right? It's doing this stain, and it's doing this sort of AI machine learning business, right? And so we are able to fine tune our monitoring of our patients, more carefully based on this Straticyte score. So in a way, it's additional information that we'd love to have in terms of prognosticating for our patients.
Okay. So I'm going to get back to some other questions about that, but Dr. Rennick, I understand that you've been using Straticyte in your practice for some time now. And can you please share your clinical experience with this test?
Yeah, I've been using it since 2014, and I got involved with using the test because I got caught at a weak point. There was a patient that came into my office, had a small lesion, and that lesion was turned out to be a mild dysplasia. And they were going off to do a tour of the States, and they were going to be away for 8 months or so. And they asked me if I should be too concerned about it. And I said, I don't think it's going to be a problem. Well, they got back from their trip, and then they had a 1 centimeter diameter carcinoma, and I felt like I'd been a total failure. But when you sit down and look at what we're using currently to try to manage these patients, it's no surprise. Simon was talking about the reproducibility of dysplasia and of dysplasia grading, and most people aren't familiar with it. But if you take 2 pathologists and give them the same slide, they agree 70% of the time. That's it. You give the same slide to 3 pathologists, they still won't come up with a consensus. They'll agree about 90% of the time. And if you give a slide to a pathologist and give him the same slide a week later, he agrees with himself 80% of the time. And so, it's not very reproducible. And if you take a look at the predictive value of epithelial grading, it's in the order of 65%. Well, a coin flip is 50%. But we're hanging on to it. This is what we're using. So I started using this. David Mock, actually, who's Dean Emeritus at U of T, he was the one that got me involved with this. And I've been using it ever since. And over the course of time, it's really changed, my practice. As Simon said, patients return to your practice. They don't know what the heck dysplasia grading is. Most of the people in the audience here barely understand what dysplasia grading is. All they've heard is that I don't have cancer, and that's it. They're out the door, and you're lucky if you ever see them again. We know that one of the big problems with oral cancer is that because of the poor follow-up, these patients present, to your office years down the road with a tumor that now is going to be, involve a lot of surgery and radiation. And so that's how I got involved with it. It was actually through David Mock, and I probably have at least well over 100 patients that I've tested with Straticyte. Today in my office, I had just between 2 o'clock and 4 o'clock, I had 3 patients with dysplasia. All 3 of them ended up getting Straticyte testing. And then I had a poor fellow that had a 4 centimeter diameter carcinoma that probably wished he had have gotten it. So, Straticyte's been really helpful for me in trying to manage these patients. What I actually do with my patients now is this. Patients that have severe dysplasia need to be respected. We all know that. Patients that have a dysplasia biopsy done are going to, 50% of them are going to have a recurrence of their lesion in 18 months to 2 years' time. So all of my patients, I don't care what the dysplasia grading is, what their Straticyte score is, I see them every 3 months for a minimum of 18 months and usually 2 years. Those patients that have severe Straticyte or severe dysplasia grading, this is basically what people are now calling carcinoma in situ. These patients are very high risk, and so I see those patients every 3 months. The question is, what do you do with the other patients, the mild, moderate, and no dysplasia cases? And so for those patients, again, I see them every 18 months to 2 years because I know that's the recurrence period. And then after that, my follow-up is based on their Straticyte score. If their Straticyte score is high, then I'm going to continue to see them every 3 months for the course of 5 years. If their Straticyte score is low and they've got, they have non-severe dysplasia, then those are patients that I'm likely to see maybe yearly, or I may even send them back to their primary provided that if in cases where it's a long distance away. But I mean, that's my policy. That's the way I manage these patients. It's not a policy of the company or a policy of any oral surgery association. We were talking about follow-up. How follow-up is so important, and follow-up is so much better. These patients that have had Straticyte testing done, they have a number that's applied to them now. When they come in the office for follow-up, I can't remember what their number, but they know what their number is, and they're always there for follow-up. I would say that my follow-up, my return rate now is probably well over 95%, and I certainly didn't have that when I was using that dysplasia grading. One of the other sort of things that I've noticed also is that these patients are more likely to give up smoking than they did when they were told that they just had dysplasia. They didn't have cancer. Hey, you know what? I'll just keep smoking. But now that they've seen that, well, my risk of cancer down the road is 87%. Well, yeah, maybe it's time to kick the habit. So that's I've now been using this. It's almost 10 years now, but it's worked out very well. The other interesting thing with it that we should probably speak about is when these recurrences occur and the patient has a high Straticyte score. I know that these are patients that are likely to have a carcinoma. And so when the recurrence happens, then my resection is going to be wide and it's going to be deep. So I may go with even a 1 centimeter resection margin on these cases, and I go deep on them and find that, yeah, you know what, they have carcinoma. It's microinvasive. It's less than a millimeter in depth. All margins are clear. I send them to the cancer center, and that's the end of their treatment. And it's the Straticyte test that sort of dictated me to approach these patients in that fashion rather than their dysplasia grading.
And is there any outcome research in other studies to show a more positive result with that approach that you've just described of the wider margin with a high Straticyte score?
Yeah. So, to date, all the studies that we've done, and we've got now 100. Well, we've got about well over 1,000 cases. The studies that we've published have all been, retrospective in nature. You've got a test that's a 5-year predictive test, so you've got to get 5 years of data, and so if we do retrospective, then it's fairly simple, it's fairly inexpensive. But if we're going to do a prospective study, then we're going to have to start accumulating patients over a period of time, and it's going to take maybe 10 years to get the volume of patients that you want to do a prospective test. And if you're going to try to do a randomized test, then it's going to take even longer, or we're going to have a wide network of clinics in order to develop the patient base for that. And this is a relatively new product. It's commercialization's only been about 1 year so far.
Given that you both navigate in the sphere of treating these types of conditions, is there any correlation, or can you comment on any correlation between a high Straticyte score and the potential for multifocal disease? In other words, you've biopsied that lesion, the patient has a high Straticyte score. Are there not situations where patients may be prone to having multi-site malignancies?
You want me to take that one, Simon?
Yeah,
Okay.
sure.
All right. So if you actually looked at some of the studies on recurrences of OPMD lesions, you'll find that in most cases, as you say, the recurrences are actually not at the site of the original biopsy, but they are at remote sites. Now, Slaughter, in I think it was 1952 or 53, proposed the concept of field cancerization. It was a little simplistic, but it was a useful tool at the time. His comment was that we probably have multiple islands of exactly the same tumors developing at different sites. We now know that that's a little bit simplistic, but there's a number of things that we're actually looking at, the proteocyte companies looking at. One is the use of simply scrapings to do a Straticyte test. And what we find is the S100A7 biomarker actually is expressed all the way up to the level of the mature keratinocyte. So it might be possible for some, RPN up in Yellowknife to do a scraping and send it in for Straticyte testing. We're looking at a couple other things. The original study was looking at the prognosis for patients that had cancer, and I think we might look at that again. Patients that have had tumors removed and then they've had high S100A7 content. How did they fare in their treatment? Dr. Mark Darling out in London has recently done a study where he looked at maxillectomy specimens. And so these are maxillectomy specimens for cancer. And if the patients had high S100A7 scores at their margins, then those are patients that really didn't fare very well down the road. One of the big problems also in cancer surgery is what do you do with the T1 lesion? So you've got a small diameter lesion. You do PET scans or CT scans, and you've got in clinical exam, and it's node negative. You know that 25% of those patients are going to actually have microscopic disease. Could S100A7 be used to determine who should actually have an elective neck dissection? I don't know. There's lots of applications to it. We could use S100A7 with a fluorescent marker to try to guide resection margins intraoperatively. But we only have so many people and so much money to get this research done.
Yeah. So I want to get to some questions from the audience, if that's okay. First of all, at the outset, we started to look at outcomes with breast cancer and prostate cancer. And I'm going to make a statement, and please tell me if I'm wrong, but you mentioned that the dysplasia interpretations are very variable intra-pathologist and from pathologist across the board. It's hard to get a strict definition or classification of dysplasia. Is it not true that in the treatment of, or in the analysis of breast cancer and prostate cancer, that specific staining, which Straticyte seems to be obviously a form of staining for the biomarker in question, along with AI analysis of cell geometry, but is this not analogous to what we do with prostate and breast cancer in terms of the specific stains? But let me back up for a second. Is the histologic interpretation or the grading of prostate and breast cancer, is it not prone to the same variation in pathologists, from pathologist to pathologist? And is that not an analogous situation?
I'd like to answer that one, Simon. I actually was, we actually did a presentation at the the first global symposium on AI and dentistry at Harvard in December. And there was a very interesting presentation that was done by one of the people at Google. And so urologists and prostate pathologists have been using the Gleason scoring system for many, many years to try to predict future outcomes for patients with prostatic hypertrophy. And again, I can't tell you exactly what the numbers are, but it's got very poor reproducibility and it's got very poor predictability. And so there was a group of urologists actually approached Google and said, any way you can help us with this? And I was at this lecture with Dr. Tony Moreland, and the hair on the back of our necks stood up. We thought, oh my God, they're doing exactly what we've been doing. This will be an interesting talk. And so what they did was they were able to teach a computer to do a better job of the Gleason scoring, and they actually had not only a more reproducible model, but a better predictive model. But then they had a hard time selling it to the pathologists and to the urologists. And so there's that probably answers your question about the Gleason scoring. And this is actually common in a number of different clinical scenarios. There are other groups that are struggling with the same thing, trying to find quantifiable biomarkers. There's a big movement recently. There's a paper by Mahmood, which looks at moving away from WHO oral dysplasia grading into cytology again and training computers to do it. Well, we're already there. We're using computer training of cytomorphometrics and then also combining this biomarker, as part of the Straticyte test. So I like to think we're at the cutting edge of technology at the present time.
I have a question from the audience here. Is there any research on how these biomarkers may be modified? Is there such a thing as reducing a person's biomarker load?
That's a good question. Yeah, I mean, I wasn't really, I'm not sure what they mean by reducing a biomarker.
Well, I think if you have a high Straticyte scores or anything from a behavioral or pharmacologic point of view that can be done to effectively reduce.
Right. Okay. Well, I mean, I think also to be fair, we have to step back and say, what we're looking at here. So regardless of the biology, remember, we're looking at correlations here, right? So you can say, yeah, S100A7 was related to psoriasis and bacterial invasion and all those kind of things. But at its core, we've found an interesting correlation here on a single biomarker using this particular technique, right? This staining with this machine learning algorithm, and we've been able to sort of risk stratify patients. Okay. Now, that is a separate issue in terms of like what it's doing biologically. So yeah, I could tell you from a research standpoint, I find it really interesting because, I work with folks at MD Anderson and we're really interested in immunotherapy, right? And so I'm particularly interested in the role of S100A7 and, the immune response to early dysplasias, because if you look at some of the literature out there, cells that express S100A7, they decrease a chemokine called CXCL9 in lung cancer, and that ends up having less immune cells coming in. And if you have less immune surveillance, it means you maybe your body's missing that dysplasia, and it's allowing it to go to cancer. So, regardless of how I feel about it on the research side and the biology, I'm not sure if it's really a matter of trying to reduce a biomarker or such. The biomarker, it's just like it is what it is. Right? It is a characteristic of the tissue that allows us to identify whether a person has a risk or not. It's the same thing like HPV, right? I mean, the best known biomarker in head and neck cancer is like P16 as a surrogate marker for HPV positivity, right? And we know through numerous studies that if you're HPV positive, your prognosis for if you have oropharyngeal cancer and you're going to get standard chemoradiation therapy is like pretty darn good in comparison if you don't have HPV, right? If you're HPV positive, you're of a 80% cure rate with standard chemoradiation, and you're 50% if you don't, right? Now, regardless of trying to reduce someone's HPV or not, that's what the biomarker allows us to do in terms of prognosticate and guide our treatments. So this
on the subject of immunotherapy, there's a question that, and I'll read it to you. It's stated that so much is currently and successfully going on with immunotherapy with melanoma, NSC lung adenocarcinoma, only to name a few. How would you say oral cancer is faring in that arena?
So I think the easy answer is we're not doing that well. So, in terms of FDA approvals, nivolumab, pembrolizumab, they got their approvals around 2015, 2016, right? And so the initial indications for immunotherapies in oral cancer were if you had recurrent or metastatic disease where you'd already failed chemotherapy, right? And then those people were getting about a 20% cure rate. And then, more recently around 2019, 2020, they had updated indications. So now it's first-line therapy. So you can get immunotherapy, first-line therapy, if you've had recurrent or metastatic head and neck cancer, and you don't have to have failed chemo ahead of time, but we're still looking at a 20% cure rate, which means that we're not curing 80% of people. So there's definitely a lot of room to grow in terms of what immunotherapy can.
Okay. So the next step is probably I mean, I guess the next question that the same person has asked is, if one displays characterized and indicative biomarkers, is the next step not designing immune targeters or?
Yeah, absolutely. And so, I think we also want to make really clear, this is not the NL and BL test, right? So specifically, so let's just quickly talk about like companion diagnostics, right? So if anti-PD-1 monoclonal antibody therapy is the standard now, like FDA approved standard for immunotherapy, its companion biomarker diagnostic is PD-L1. Right. So you have a patient who has oral cancer, you're going to send it to the pathologist. They're going to do an immunohistochemistry stain for PD-L1, which is the ligand for PD-1. And if they have a combined positive score that's, more than 20, for example, it means they're blazing hot on PD-L1, and those people may do better, on anti-PD-1 therapy. So that is a companion biomarker that says that PD-1 therapy may work well. There is no companion therapy right now for S100A7. So the best we have right now is, hey, we have this one biomarker. It has this morphology when we do the stain in terms of the cells and the staining pattern. And we know if you're high risk, moderate to high risk of progressing to having oral cancer or not. And that's the best we can do right now, just to be clear. But it's still, as Barry would say, it's still better than just old school, H&E from 50 years ago in terms of where you can't really prognosticate those things.
There does seem to be, sorry.
We might strengthen this, our test down the road. If you take a look at the Afirma test, which is for the indeterminate thyroid nodule, or if you look at EndoPredict or MammoPrint, most of these tests actually have a group of biomarkers that they use, which fortifies their algorithm. Right now, we're pretty strong. We've got a 97% sensitivity with just simply S100A7. And so there may, down the road, we may incorporate a cytokeratin marker into the algorithm to try to strengthen it a bit. But as we add more and more cases to the algorithm, then it becomes stronger and stronger.
Right. As a profession, I mean, there seems to be a kind of a disconnect or a paradox between the fact that cure rates, the therapies for prostate cancer and breast cancer seem to have made strides and advancements with not purported, but early detection and patient sensitization across the population to getting tested for early detection. But when you think about it, I mean, the oral cavity is much more accessible and visible.
That's the crime.
So,
absolutely.
And so what's going on? I mean, are we that far off the grid and ridiculously missing early diagnoses in such an accessible part of the body? I mean, it's absurd, right?
I actually I have a slide I present sometimes at talks, and it's if you take a look at breast cancer, they've got great clinical trials. They've got a great fundraising program. They've got great research facilities. They've got great marketing. They've got they've got a biomarker, and they even have a color. And they've got mammography. They've got self examination, and we've failed in almost every one of these regards. And it's worldwide. We really need to get oral cancer out to the forefront. In the U.S., it's as Simon said, there's an American dies from oral cancer every 45 minutes, and it's not getting any better. It's getting worse. The oral cancer rates are getting higher, and it's younger and younger people that are being affected. So, there's no time like now to try to make an impact on this disease.
And can I just add to that? It's interesting. I forget. I was on a webinar. I was in a conversation with someone, and someone literally asked the speaker. They're like, why isn't oral cancer? Why aren't advocacy? Why isn't advocacy better? And it was interesting. I think it was Linda Butterfield. She was like, one of the famous sort of immunotherapy oncologists down here in the U.S. And she said, if someone has breast cancer or they have prostate cancer, they can still go on TV and talk about their terrible experience. But if you've had a really bad cancer and you've lost a chunk of your face and you have a flap there now, you're not so media, pretty for all these, campaigns and stuff. So I never even thought about that, but it's true. I mean, when who knows, how many people had never heard of oral cancer or throat cancer until Michael Douglas got it? It's just one of those things. It's a public awareness thing too.
Yeah. Yeah. So I'm just going to give the recap version for dummies. That's me. Okay. So a patient walks into my office tomorrow, has what I suspect is a dysplastic lesion.
Mhm.
I think you alluded to something along these lines, Dr. Rennick, is that most oral surgeons are going to refer this case to an oral pathologist for detection and biopsy. Am I right? In
Well,
an urban
I-
setting like Toronto, most oral surgeons are going to see a dysplastic lesion. They're either going to refer it to somebody who works in University Hospital Center, an ENT surgeon, or an oral pathologist, right?
Yeah, yeah. There was a study done. The author was Suter, Psoter, and it was in the American Dental Association 10 years ago or so. In that year, there were 2 million biopsies done for oral dysplasia and oral cancer by general dentists alone in the US. And so, I think it depends on where you practice.
Right.
Uh,
I guess that wasn't really the gist of my question. It was just an
Okay.
observation that I was trying to, realistically speaking, though, I would biopsy this case and then basically offer the patient the Straticyte test once I got back a diagnosis of dysplasia, right?
Yeah, so you do your biopsy, send it out, comes back, and it has to be one of the OPMD groups.
Right.
So leukoplakia, erythroplakia, now or simply hyperkeratosis. So
Really?
you take a look at OPMD cases. 50% of OPMD cases show dysplasia. 50% don't. So dysplasia on its own is not a criteria. If you have unexplained hyperkeratosis, this is still a patient at risk. Remember the Chattaverdi study, 39% of patients that had leukoplakia but had no dysplasia still went on to get cancer. And so, you've got your diagnosis. It's an OPMD case, plus or minus dysplasia. And then you talk to the patient. We have patient brochures on our website that you can download, clinical information that's there. I provide that to the patient. We talk about the test. The test currently in Canada is $650. And if the patient decides that, they'd like this objective study done, then the next step is for you to go to the Proteocyte website. There's a test requisition form there. You fill out the test requisition form and then send that off. And then that's all you have to do. Just simply fill out the form. So it's going to be your name, the patient's name, the lab that did the test, and what the succession number is for the specimen so that they can find it. And then after that, you don't have to do anything else. The patient care solutions, our intermediary will contact the patient, collect the $650. They'll then contact Proteocyte, who contacts the lab, and then the whole process happens. And usually have the test result back in 2 to 3 weeks.
Okay. A quick question for you, because the trigger for this is going to be seems to be dependent on who the pathologist is that interprets that slide. In the sense, so the question is, do you see any difference between, and somebody asked this in the audience, in the diagnostic acuity between a general medical pathologist versus a trained oral pathologist?
I don't want to talk about, I guess in general, we at our center, we send to our dental pathologist, our oral pathologist. So,
Okay.
my clinical day in the county hospital, sometimes you'll get back a very generic, kind of answer from the medical pathologist. I mean, they're great for the whole body, but for certain dental pathologists, and then we just kindly ask them, can you please
Right.
send to the dental school
So the take-home message is try to send your stuff to an OMFS or an oral pathologist, an OMF pathologist or a oral pathologist.
Mhm.
Yeah. Okay. Are there any, do you guys have any closing remarks or thoughts you want to share in closing?
Yeah.
Well, I would
Good.
just, sorry, Simon. I would just say that, this test is not meant to be a standalone test. We're still going to do conventional histopathology. We're still going to, at least for the time being, we're going to do dysplasia grading. Severe dysplasia certainly needs to be respected. And then, it's the other ones that we struggle with. And it's those tests where, those cases where Straticyte, can be helpful. You still need to, as a clinician, you still need to take a look at, Simon was talking about the SPATE algorithm and the Liverpool algorithm. And if you're not familiar with those, you should have a look at them, where they take a look at all the demographics, all the clinical findings, and it all kind of funnels down. The only problem with those algorithms is the final point, the final gateway there is dysplasia grading. So I like to think that you kind of come down to that point, and then at that point you do your Straticyte test, and then you figure out how you're going to manage that patient. But every single OPMD patient needs to be managed individually. They're all different people. Some are going to follow your instructions. Some of them aren't. Some of them are coming from a distance. So, every case needs to be managed. There's no cutter recipe for every patient.
Right. Well, if there's no further comments, I'd like to thank you both for what I think has been a very educational and enlightening presentation on the Straticyte test and on the Proteocyte product. We're looking forward to perhaps, I know the company is going to be at our Saskatoon meeting. While I thank our participants for being with us this evening from the CAOMS, I'd like to remind everybody, if they haven't registered, to please consider attending the CAOMS meeting. And I think with that, I will close out the session and look forward to the opportunity of meeting you gentlemen in person at some point in time. Thank you so much.
Thank you.
Thanks. Have a good night, everybody.
You as well.
Great.